Thank you, Richard. And thank you for being here today. And thank you to all those who are listening on the live stream. Global Surgery 2030. The Lancet Commission in global surgery set out to generate a broad and sustainable improvement in surgical and anaesthesia care across all lower and middle income countries. The Commission also set out to inform and drive policy change for surgical and anaesthesia care. The vision, simply this: universal access to safe, affordable surgical and anaesthesia care when needed. And I want you all to go away with that message very clearly, to memorize it. Global surgical inequity has been around for a long time. We've been aware of the inequity, even if we haven't measured the extent of the inequity. Let's wind the clock back to a Sunday in Mexico City in 1980. And on the 29th of June of that year, Dr. Halfdan Mahler, the then Director General of the World Health Organization, spoke to a group of surgeons at the International College of Surgery meeting in Mexico City. And his title was Surgery and Health for All. And his focus was global surgery inequity. What did he say? Well, he said a lot of things, but including this: the vast majority of the world's population has no access whatsoever to skilled surgical care, and little is being done to find a solution. I beg of you to give serious consideration to this most serious manifestation of social inequity in healthcare. Now, it's interesting that 34 years later, at our inaugural meeting in Boston, on the 17th of January 2014, Dr. Jim Kim, the president of the World Bank Group, also spoke about global surgical inequity and said this: I urge you to challenge this injustice and to build a shared vision and strategy for global equity in essential surgical care. You can make the case that surgery is an indivisible, indispensable part of healthcare. Now, when you put these two statements together, it's seemingly rather depressing. It's as though very little has happened over 34 years. But actually, for those of us in the global surgery community, I think we recognize that quite a lot has been going on. The unplowed fallow ground has changed. And as John Meara and Sarah Greenberg eloquently write in the comment published today alongside this commission, Kim's words landed on fertile ground, perhaps unlike Dr. Halfdan Mahler's, prepared by the hard work and dedication of numerous individuals and groups, such as the Bellagio Essential Surgery Group, such as the second and third edition of Global Priorities in Developing Countries, Disease Control Priorities in Developing Countries, the WHO's Global Initiative for Emergency and Essential Care, and thousands of frontline providers who have been struggling to provide surgical care. I think it's tremendous that some key people are in the audience today, like Heidi DeBass, Atul Gawande, others involved in disease control priorities, Mina Sherian at the Global Initiative for Emergency and Essential Surgery. It's on the back of these individuals and many others that Kim's words, I believe, have actually gone into more fertile ground. The call came, as Richard, as always, eloquently described, the pivotal time in global health. But I think for the reasons I've just said, it's also a pivotal time in global surgery and anesthesia. I spoke about the need to inform and drive policy change, and that, I think, relates to the global health agenda, an agenda that for the last 20, 30 years has had a great focus on individual diseases. There's been disease-specific advocacy, disease-specific funding, disease-specific interventions with some tremendous results. But in parallel to that, there's been far less of a focus, as we've just heard, on the wider health system development and the integration of services and the important part that the hospital plays, whether it's a frontline hospital, a small district hospital, or a larger urban tertiary centre. And so we really need to see a shift in this global surgical agenda. Treatment for surgical conditions, a broad range of diseases, represents approximately 30% of the global burden of disease and cuts across all disease categories. So for that reason, it's important. And the fact that surgical and anaesthesia care has not been prioritised is serious. This results in loss of life, reduced welfare for millions, and in fact, it affects the economic productivity of nations. More on that a little later. But to change the agenda, we need evidence. Someone here who runs an evidence to policy institute. It's important. And I think there's been a comparative desert in terms of data for global surgery and anaesthesia care. I put up one paper, which I've always thought was a very significant paper, and that was on Tom Weiser and his group, looking at the estimation of the global volume of surgery from a few years back. And that was important, particularly regarding the demonstration of the inequity. So if you have here, if I can get this to work, 3.5% of the 234 million operations performed, 3.5% occurring in the world's poorest countries, where 34.8% of the world's population were living. But there was a comparative absence of data, and so the Commission had to produce some new research on service delivery, on workforce, on particularly finance and economics. What's the process? Well, it all got started, and I'm hugely grateful to Justine Davis for really linking the wider global health community to the surgical community. And in a conversation we had with Lars only 2 years ago, in January of 2013, it all sort of started from that time. And 2013 was an exciting time when John's really been the overall leader. We might have 3 co-chairs, but we've got one overall leader. And John was able to put together a strong team of commissioners. And here they are. This is the photo in Boston, and with our vision. If you haven't memorized it, work on it. Universal access to safe, affordable surgical and anaesthetic care when needed. And the commissioners from all across the world, from Ecuador right across to Mongolia, came together at that first meeting. And then there was a series of a second commissioner meeting in Freetown, just as the Ebola was really taking off. And that was an important meeting because the working groups, the 4 working groups, presented their findings to a group of leaders from 28 different lower middle income countries that came to Freetown, and we tested our initial findings, and that was really important. And that was where I think the key messages were crafted. We then went away and wrote and came back in Dubai and addressed hundreds of pages of comment, mainly positive, thankfully, and finally submitted the report. And then came together for a special meeting in Bellagio, where we were able to think about implementation. How are we going to take this forward? This is not to be put on a shelf and left. This is the beginning of a process. If we're really going to turn the tide and see surgical and anaesthetic care priorities, that's going to be a decade-long process. Alongside these commissioner meetings were a set of regional meetings, and this was so important for us to really get out and listen to surgical implementers and leaders across the world. So that was the process. We wrote to every Ministry of Health. We wrote to hundreds of global health organizations and funders, and we most importantly went out and listened to front care providers and patients in sometimes very remote areas, to really understand the challenges people face in delivering surgical care. Right at the beginning, we felt that it was actually important to define global surgery. We used this term. No one had actually defined it. And we felt that was important, partly because then we can define the scope of this commission. What was this commission really doing? And actually, what were we leaving out? And so we came up with this definition. And how do we do this? Well, we took the central tenets of global health, the importance of interdisciplinarity, the importance of the focus on equity, the importance of the synthesis of clinical care and public health. And we took some of these and we put them into this definition. And it is this: a field that aims to improve health and health equity for all who are affected by surgical conditions or have a need for surgical care, with a particular focus on underserved populations in countries of all levels. There's some considerable inequity in high-income countries for the marginalised, the uninsured, indigenous populations, but with a focus on underserved populations in countries of all income levels, as well as populations in crisis, such as experiencing conflict, disaster, and displacement. And I say that in order to demonstrate what the scope of this commission is. We in this commission focused on underserved populations in lower and middle-income countries. That was the scope. Although we fully recognise there is massive need in areas of conflict and disaster, which is very clear today. The outputs, well, I've come up here with a package. There are quite a lot of things for you to read. You need to sort of take a long weekend off or take a holiday and go away and read it. There's the report itself, and I'll focus on that in a moment. But there's a whole set of new primary research. There's a booklet here on 57 abstracts of new primary research. I think it's probably the biggest synchronous release of research data for the global surgery community, and that's important. There's a number of teaching cases that have been put together so that surgery and anaesthesia can come alive, not only in schools of surgery, but actually in schools of public health, because we need to see the two communities coming together. And all this evidence, a clear message so that the professional advocacy groups, G4 Alliance, can really pick this up, and others, of course, and really advocate for surgical care. And it's not surgery and anaesthesia versus, no. As we'll come on and talk, it's surgery to strengthen the health system. So the report itself, what does the report actually say? Well, it certainly describes the role of surgical care and anaesthesia in improving the health of individuals and the economic productivity of nations. It's not just improving health, promoting welfare of millions of people and affecting the economic productivity of nations. Secondly, it presents findings on the state of global surgical care across all lower and middle-income countries. And importantly, and thirdly, it presents a framework of recommendations, indicators, and targets needed to achieve the Commission's vision of universal access to safe, affordable surgical and anaesthesia care when needed. Coming a little slow. And so this is really important. In fact, Richard, when he sat down with John and Lars and I in 2013, he looked at us in the eye and said, targets, time-bound targets. The indicators are important. We've listened, sir. Okay, let's move on. This is the output. This is the report. It's structured around initially 5 key messages, and that's what I'm going to focus on for the remainder of my talk. But a set of recommendations as indicators that I've just said. And then there's 4 sections of the report. And following this, there'll be 4 sections of today's agenda, which are devoted to the working groups: healthcare delivery and management, workforce training and education, information, and finance and economics. And then right at the end of the report, a key part on research. What are the key research questions? How are we going to move the research agenda forward? And then finally, a national surgical plan, a template of a national surgical plan that we hope that countries can pick up. Message 1. 5 billion people cannot access safe, affordable surgical and anaesthesia care when needed. Timely surgical care is essential to reduce death and disability from certain conditions. Right now, today, there are young women in obstructed labour who cannot access a caesarean section. Right now, today, there are people of all ages with an acute abdomen that can't get the care they require. Today, there will be a lot of people who sustain road traffic accidents, agricultural injuries, that have a trauma and cannot receive care. 5 billion. It seems too much. But I think for all of us who worked in a lower middle income setting, it's certainly believable. The previous estimate was 2 billion. And that was based on one dimension, surgical capacity. Actually, the authors looked at the density of operating theatres per 100,000. But alongside that vision of universal access to safe, affordable surgical and anaesthesia care when needed, we wanted to look at the 4 dimensions of capacity, of timeliness, of affordability, and of safety. I used to think, perhaps naively, that quality and access were so far apart, but we need to bring them together. Reaching this target will require integration of surgical services across all levels of care, from the community referral networks to first-level hospitals and higher-level hospitals. So it really is a focus on the whole system. It will require a commitment to addressing factors that result in delays in seeking care, delays in reaching care, and delays in receiving care. So the dimensions I spoke about, the proxy for timeliness was the proportion of the population with serious injury that actually are transported to hospital by ambulance. The proxy for surgical capacity were the number of operations in a country over the actual need of that country, which I'll come and talk about. The proxy for safety was the proportion of operating theatres with a pulse oximeter. The proxy for affordability was the proportion of patients that were able to access care and not suffer catastrophic health expenditure. Now, this is the first advert for the lunch seminar, because in the lunch seminar, this is going to be unpacked in great detail. I can just whet the appetite, but the modelers, the 7 modelers, will be able to really go into greater depth during the lunchtime seminar. Key message 2. 143 million more procedures are needed annually at a minimum. Now, I mentioned that earlier report that mapped or estimated the met need, how many operations have been done. The Commission has gone significantly further, and through a sort of 3-step-wise process, we've looked at the total need, then we've looked at the met need, and then we've taken one from the other and come up with the unmet need, this figure of 143 million. How do we do this? Well, we first used the New Zealand National Healthcare Database to calculate the operative frequency for every disease category. And then we took that operative frequency for every disease category, and we then used the prevalence data from the global burden of disease for every disease category to come up with the need, the total need for surgery in the 21 regions of the world. And we found that 12 out of 21 global burden of disease regions do not have enough surgery going on. Our figure, our lower threshold, was 5,000 per 100,000 population per year. And 12 out of 21 of the regions don't have that figure. In fact, these regions require between 301 and 5,625 more operations per year. The greatest need is in West, Central, and East Sub-Saharan Africa, and South Asia and Southeast Asia, where well over 90% of the population don't have care. Reaching this target will require broad expansion of surgical and health systems, a doubling of the surgical workforce within the next 15 years. But this expansion of volume must run in parallel with a significant scaling up in terms of equity and safety. When surgical care is not available, that young woman that I was talking about and her child and her infant will die. If that surgery is not available, the young man with a traumatic injury will have disability and not be able to work. So this is really serious. We need to see a significant scale up. There is a shortage of what we described as the staff, the stuff, and the space to do this surgery. And this will be unpacked in the next session, in the service delivery session. But the three bellwether procedures, the three essential procedures that every first-level hospital should do are these: a caesarean section, a laparotomy, and treatment of an open fracture. And we found that many first-level facilities cannot do these, but if they do these, the evidence is that they will also do all the other operations that are needed within the district, or many of them. Key message 3. Key message 3 is around the fact that so many people who access surgical care are pushed into poverty or suffer catastrophic health expenditure in paying the direct costs for care. Catastrophic health expenditure, for those who don't know, and I didn't know at the beginning of this process, was 40% of your income spent on direct costs of healthcare after you paid for food and accommodation, or 10% of your total income. 33 million people are pushed into catastrophic health expenditure paying for surgical care, and a further 48 million are pushed into catastrophic health expenditure because of the indirect costs. The travel from the remote village to the first-level hospital, the care of the accommodation requirements or the food that they need while they're receiving care. 25% of all people requiring surgery will be pushed into catastrophic health expenditure. Why? Well, this will be unpacked by Gavin Yamey in his presentation this afternoon, and Gavin's led the finance and economics section. Financial risk protection has historically not been prioritised. There's been this heavy reliance on direct out-of-pocket payments. The poorest, who most need financial support, don't have it because there aren't central taxation schemes or social insurance schemes. The golden decade for health, in terms of development assistance for funding, and it has been a golden decade, has not been a golden decade for surgery, or at least, as far as we know, it hasn't been. Key message 4. Investing in surgery is affordable, saves lives, and promotes economic growth. Now, should we unpack that a little bit? Well, I've already demonstrated that it saves lives. How many lives? Well, it's huge. It's 16.9 million lives were lost in 2010 from conditions requiring surgical care, or certainly requiring a surgeon and anaesthetist in the management of that condition. That's 77.2 million disability-adjusted life years. Could be averted each year if we provided basic surgical and anaesthetic care. It's possible to scale up surgical care. Countries like Mongolia and Mexico have achieved it. If lower middle-income countries was to scale up surgical services at the annual rate that Mongolia has scaled up, about 9% a year, it would cost $420 billion between now and 2030. 420 billion. Now you might think, well, that's crazy, that's far too much. But actually, that's only 1% of the health budget in higher middle-income countries. It's 6% of the health budget in lower middle-income countries and 8% of the health budget in low-income countries. So for the higher middle-income countries, they should be able to meet that. For the lower middle-income and the low-income, there will be need for ongoing development assistance. The figure is 350 billion from 2015. That earlier figure was from 2012. From 2015, today, through to 2030, that's the figure. And that will ensure that the 88 out of the 103 countries who aren't doing enough surgery, that'll ensure they get up to the figure of 5,000 per 100,000 operations per year. Now, another way of looking at this is actually to think of it as a good investment. Because the modelers, and we've got some pretty smart people modeling here, I certainly couldn't have done it, the modelers have come up with this figure of 2.3 trillion. That's the lost economic productivity if we don't bother, if we just maintain the status quo. That's the figure. And so this is a good investment, and this will help countries develop. The main issue for surgical care is injuries and then neoplasms. And this we're talking about up to 2% of the GDP. So if there's not this investment, there's the potential to knock 2% off GDP for middle-income countries and low-income countries. Key message 5, no figures, you'll be pleased, you can relax. But it's probably the most important message. And it's the message that surgery is an indivisible, indispensable part of healthcare. It's not, as I said, surgery versus mental health or surgery versus maternal health or child health. It's surgery to strengthen the health system. Surgery has a role in the care of populations because surgery is important right across the life course, from the infant who's born and needs urgent surgical care, right through to the older person who needs a cataract operation. It's important across the life course. It's also important across every disease burden, every disease category. Surgery is required. And surgery is also involved in all aspects of care, from prevention right through to palliation. So it's important. It's necessary to achieve the present global health priorities, particularly in maternal and child health. Even in communicable diseases, surgery has a key role to play. But as I've demonstrated by the impact on economic productivity, it's also important in terms of ending poverty, the Sustainable Development Goals, and reaching universal health coverage. So it's necessary to build the wider health system and to promote development. The Commission vision, universal access to safe, affordable surgical and anesthesia care when needed. And I think John and Lars and I and all the commissioners, all the team, would say that if we address these 5 messages, and if we're serious, then we can see this vision become a reality. So it's an exciting day ahead. And then I want you to go away and read. There's the report. There's the 57 primary research papers in the abstract booklet. There's a special edition of Lancet Global Health published today. And this particularly importantly, because this has the key messages, the evidence behind those key messages is in here. And then actually a shortcut is to pick up these policy briefs and read these. And that's perhaps the quickest way to understand what this commission's all about. I'm going to hand over now to Justine, and I've said a little bit about Justine earlier, her role in not only connecting the Lancet to the global surgery community, but actually being with us on the whole journey. Whenever John and Lars and I have suggested something, Justine's gone away and said, yes, that's possible. And it's been tremendous, your support. Justine is the senior editor of Lancet Diabetes and Endocrinology, and she's had a long time at the Lancet, and she's done many things in her career which are well put in the bio. So I won't delay further. Justine, come up and lead the first session on service delivery.